We are a relatively new school, and I'll let the slides catch up with me. It's at Lincoln Memorial University, and Lincoln Memorial has been there for 100 years. And it has all the bells and whistles that go along with the campus. It's got several undergrad. It's got an undergrad program, an MBA, an education program, a very large nursing school. And 6 years ago, they decided to add a medical school. So we've graduated 2 classes now, and we get about 50% of our applicants from. We're not a state school, okay? So we don't have any allegiance to Tennessee. There's no tuition break if you're from. Anyone from? You're from Tennessee? No? Oh, okay. Where? Oh, yeah. Okay. So have you seen the school? Yeah. Okay. We get about 50% of the school of the students are from around there: Tennessee, Virginia, Kentucky, North Carolina, and then 50% from all over. And every year we get probably 10 to 15 students a year from Florida, and we have some students from here. And the impetus for the school, I'll let the picture catch up. It's kind of interesting. The name of the school is the DeBusk College of Osteopathic Medicine. And Pete DeBusk graduated from there, and he's about 65 years old now. And this was back when he was about 25. He was a pharmaceutical rep, and he had a friend who had a cast on, and the cast, it was raining out. The cast was getting wet. And he took a hush puppy shoe and took the sole off it and fashioned it for the bottom of the cast, so that his friend could walk around and not get the cast wet. That was his first patent, and since then he's got about 40 patents. He's very inventive, and he's the largest producer of durable medical goods in the world. And it's called DeRoyal Industries. They make a lot of orthopedic products. So if you're into orthopedics, we have a lot of that. And he decided he wanted to do something for the school, for this area, so he built this medical school there. And because of the lack of primary care doctors in that area, they decided to put a DO school in. Because DO schools, are you guys familiar with DOs a little bit? Okay. They decided to put a DO school in there because about 70% of a DO school's graduates go into primary care. Now, primary care, sometimes people think of that as just family practice, but it's really family practice, internal medicine, OBGYN, pediatrics, and ER, and some people will even put, some organizations will even put general surgery in there. And so we've graduated 2 classes now, and like most DO schools, we follow that trend, about 70% into primary care and 30% into specialties. Now, because I don't know, how many freshmen? Freshmen? Okay, how about sophomores? And juniors? A lot of juniors and seniors? Okay. Are you seniors in the ACOMAS application pool yet? Yeah? Okay. So you guys know about osteopathic medicine. But the freshmen, DO school is very similar to MD school. They do the same, it's the same curriculum for the most part, with one extra step. The DOs also take osteopathic manipulative medicine. So they take, for the first 2 years, all the traditional courses: anatomy, physiology, pharmacology. My computer's going kind of slow there. That's not East Tennessee. I used to live here in Florida, in Bradenton, Florida. I taught at LECOM Bradenton for 2 years. Some of you might have heard of that. And DO schools in this part of the country are growing very quickly. They really started off in the Northeast, in Michigan, Ohio, New York, Pennsylvania. There's a lot of DOs in that part of the country. And then about 35 years ago, they kind of leapfrogged to the West Coast. And they're very popular on the West Coast now. And it's only in about the past 10 years that they've started to really pick up in the South. We're a new school in Tennessee. There's 2 new schools starting in Alabama. One in Dothan, Alabama, and one in Auburn. One at Auburn. The one at Auburn was just announced. There's one in Mississippi. There's one in North Carolina, South Carolina. Virginia has one. Florida has 2.
Wisconsin.
Yes. Well, have you heard about that? They're talking about it.
It's under decision still.
Yeah, yeah. I don't know what will happen with that. Hopefully they will.
In Indiana,
yes, in Indiana. Yep, Indiana has one starting. So it's growing very quickly. And if you look at the physician workforce right now, about 6% of the practicing doctors in the country are DOs. So you could look at that and say that's a relatively small number. However, by the year 2015, if the growth rate keeps going the way it's supposed to be going, about 20% of the DOs sitting in the first year of medical school, 20% of the medical students sitting in class that first day of medical school will be DOs, okay, because of this growth rate. Catch up with this. So that's the school. Very different from here, okay? It's in the hills. It's in rural Appalachia. It's a very mountainous area. It snows a little bit, but not much. If it snows at night, it's usually gone by noon the next day. Although, even if it snows a quarter inch, it pretty much shuts down everything. Because they just don't have the snow removal stuff there, and it's very, very mountainous. It's only a town of about 3,000 people too, so it's very rural. There's a metropolis next door that has 15,000 people. But the medical students, it's a very easy lifestyle. I think it's probably the cheapest place in the country right now to live. It's not the cheapest, it's right up there. And the movies are $3.50. Okay. Those are first-run movies. Okay, it's not Gone with the Wind and black and white. First-run movies. Actually, 5 years ago it was $1.50, and then the medical students moved in and they jacked the price up. This is just a picture in the morning of the building. This is the first building we built. Is 100,000 square feet, and it's got all the technological bells and whistles you can think of. It even has, and I don't have a picture of it. Right out in front of the building is a driving range and a 3-hole golf course. So you can go out there. I think we're probably the only medical school you can go out at lunch and go pitfall. And of course, there's a lot of jokes that because doctors aren't very good golfers, so we had to put this in there. And we just finished this building. This shows it under construction, but it's now finished and open, and that's 140,000 square feet. And basically, the first year medical students are in this building, and then the other building I showed you is where the second year medical students are. This map is kind of interesting. It's broken up by county. And everything in yellow is a county that the federal government says is medically underserved. Okay? So according to the federal government, there's plenty of doctors in the big cities. There's no real shortage of doctors for the most part in the big major metropolitan areas. But as soon as you get out of there, there's a shortage of doctors. Thus the school, and we sit less than a mile from the Virginia border and about a mile from the Kentucky border. So we're right in the corner there of those 3 states. One of the things, and if you're a senior you know this, but if you're a freshman and sophomore you might not know, or there's sometimes a myth that DOs can't do everything an MD can do. There's no specialty out there that is only open to MDs. Any specialty that an MD can go into, a DO can go into also. We have students go into surgery, psychiatry, cardiology, pathology. I've had students go into neurosurgery. You name it, DOs can go into it. It's very hard to go into a hospital, a major hospital anywhere in this country and not find a DO. Just shows our first class, kind of a lead into this slide. This is a chart showing the residencies of the inaugural class, the students who went into primary care. And there's some Florida places on here. Largo, some of them have gone to Largo, various USF. So their number going to family practice, internal medicine. You'll see a lot of Tennessee, Kentucky places on here. UT Chattanooga, University of Kentucky, here's USF, Texas A&M. So they tend to go all over. There's Largo, Florida. And this shows the students who went into specialties. So you can see a fair amount went into surgery. There's a lot of DO residency programs in places like Michigan, New Jersey, Ohio, up in that part of the country. So it's a natural place for them to go.
Yesterday we had a meeting and there's like a kind of a discrepancy. If we weren't sure if a DO could do an MD residency.
Yeah.
Because a DO can do an MD residency, but
Yep.
an MD cannot do a DO residency.
Right.
That's what it is.
Yeah.
Okay.
Now, well, there are DO residencies and there are MD residencies, and DOs can go do MD residencies, and about 50% of our students will do a DO residency, and 50% will do an MD residency. Now, there are also some combined residencies, so it's really one big program that's certified by both the DOs and the MDs, and you might have 30 students in the program, 15 of them are DOs and 15 are MDs, and they're pretty much doing the exact same thing. So it's and that's probably the kind of residency that's getting more common for those combined ones. Yeah.
For the DO residencies, do they stress a lot of OT in those residencies?
It all depends. There's a spectrum. Even for the school you go to, for the DO school, there'll be a spectrum. Some DO schools stress it a lot, some don't stress it that much. And some residency programs do, and some don't. Some of it comes down to what type of residency. If you're going to go into anesthesiology, it's pretty tough, okay, to do that. It's pretty tough to practice osteopathic medicine, although there would be anesthesiologists who probably disagree with me because they'll say that there are some techniques that you learn for when people come out of anesthesia to help them feel better right when they come out. Orthopods will tend to use it more. I mean, hopefully our students would be hopefully even orthopedic surgeons would be more willing to look at other alternatives before just getting in there and cutting. Family practice, you'll tend to you can do it more. Let's get this. We talked about that slide. An easy way to talk about it is the differences is some conditions. Okay, if you have appendicitis and you go to the hospital and you see a surgeon, whether the surgeon's a DO or an MD, they're going to do exactly the same thing. Okay, there's nothing a DO can do if you have appendicitis to save your appendix. Okay, so the DO surgeon or the MD surgeon would take your appendix out. If you're diabetic and you go to the internal medicine doctor, endocrinologist, DO or MD, it's probably going to be pretty similar. Okay. But if you're an athlete and maybe you're a football player and you hit your neck, okay, you're on the line and you run into someone. How many of you have had anatomy before? Okay, so there's a lot of structures up in here, okay, that can get aggravated. And so you hit your shoulder and the next day you wake up and you're sore and you go to the MD, and the MD is probably going to prescribe a pain medication, okay, and maybe refer you to physical therapy. The DO, though, will work on your neck for a while, because you have some muscles up here that can pinch nerves. Okay, those muscles become aggravated, stretched. The DO might try to relax those. You have some joints up here, and there's some things that go under and around those joints. So the DO is going to make sure everything sits back like normally. Okay. One thing about a DO school is you will learn your anatomy very, very well. DOs. Oh, by the way, I teach gross anatomy. I really didn't introduce myself. I teach gross anatomy to medical students. And I teach neuroanatomy. I also am the dean of students, so I oversee admissions and all the sort of non-academic stuff, financial aid, health insurance, the dorms. We do have dorms. And I recruit too. And since I'm from Florida, I welcome any chance to come back to Florida and recruit too. If you need me to come back again, let me know. So I do all that, and I also, on the side, I moonlight for Kaplan too. I teach the board review for gross anatomy, or for the anatomy section of the boards for both the MD and DO schools. And one of the things the anatomy section of the boards is gross anatomy, histo, embryo, cell biology, and neuro. So when I teach that stuff, whether it's MD or DOs, it's exactly the same. It's exactly, the heart is the heart. Okay, there's no difference for a DO or an MD. So the DO would work on your neck for a while. Now, from the patient's point of view, that's a nice thing, because you will probably not be cured after that, but you will probably feel better. And from the doctor's point of view, it's also very nice because you have something that you can immediately do for that person. They will probably walk out thanking you for that. Who's been treated by a DO? Have any of you been? Okay. Whoa.
Sorry.
Did Did it work? Did you like it?
It was really simple. It was they were just showing us how they learned a technique where they allow a lot of oxygen to get released into the brain. If someone comes in for a headache, instead of providing them with just pain medicine, they're like, oh, well, massage the occipital lobe, and then allow more oxygen to go into the brain, and it kind of releases your headache.
Yeah.
And they did it to the point where you'd watch someone like hold their neck up, and they would do it, and the person's entire head would just fall into their palms because they relaxed the muscles so much.
Yeah.
It's kind of cool.
Yeah. So it is nice when you can do that for patients. It's very simple things. In fact, if you're a DO and you're like in a combined DO-MD residency, you will probably find that you're treating the MDs too. You're full of MD residents for things like that. So, and at the end of the doctor working on you, or working on the patient's neck, they can also prescribe a pain medication, okay, just like the MD. A lot of times students come in and we're interviewing them and we say, how did you first learn about osteopathic medicine? And they'll say, well, you know, the whole time I was growing up, I had a pediatrician, the family pediatrician was Dr. Smith. And Dr. Smith was a great doctor. And just when I told my parents, when I mentioned I was going to be applying to DO school, they said, oh, did you know Dr. Smith was a DO? And they just never knew that. They just knew him as Dr. Smith. This was sort of a similar example. This doctor is in the military, and he was in Afghanistan, and troops came under fire up on the front line, and he took his unit up to the front line, and his medical unit and himself came under fire. Small arms fire, artillery fire, and all that. So reporters heard about it, and Newsweek went over and spent a whole week with him, and shadowed him and followed him around and all this, and no one ever thought to ask, where'd you go to medical school? They just called him Dr. Jadek the whole time. And when it came time for the cover story, it came out as Hero MD, but Hero MD was really Hero DO. They never even thought anything differently. And the other purpose of this slide is that military, we have a lot of students who go in the military. The military loves DOs. We have about 60 students spread out over 4 years getting a military scholarship. And if money is any kind of issue, even if money's not an issue, it's a very good program. They pay for everything, including your salary, all your books, the whole deal. When you're done, they have very good residency programs. It's a pretty good lifestyle, as long as you don't get sent to the front lines. But it's good hours. You don't have to have malpractice insurance, all that. I have never had a student who's regretted doing it. And this just shows how it's hard to go in a major hospital and not find a DO. This is from Vanderbilt's alumni magazine. So Vanderbilt's in Tennessee, pretty close to us. It's obviously a great medical school. It's very research oriented. But even there, they have DOs. This girl she was in an accident, amusement park accident, and a cable cut off her ankles here, cut them right off, and they reattached them. And the surgeon, one of the surgeons, was a DO who did it. She's fine and happy now, so it was a good ending. As you go to various medical schools, you'll see different kinds of curriculums. The most common curriculum is an organ system approach, okay? So when you're taking neuroscience, you're doing neuroanatomy, neurophys, neuropharm, neuropath, psychiatry, neurology. Your whole life, for 6 weeks, 8 weeks, whatever, depending on where you are, is the brain. And when you're done with that, you move on to the heart, or the kidney, or the lungs. And the whole time, the whole 2 years as you're working your way through the organs, you're also getting osteopathic medicine and also essentials of patient care. Now, one thing to keep in mind is that what this medical school is really, it's a marathon, okay? There's a little quiz you take at the end of 2 years, the boards, okay? And the boards is really a test of your time management, okay? It's how you managed your time for 2 years. It's not an exam you can start studying a month before, okay? And speaking from a person who teaches a review course, you can't take a student who would fail the boards and in a couple of weeks get them to pass, okay? If you could do that, if that was possible, there'd be a lot more doctors, okay? So it's really how you manage your time for 2 years. Sometimes in med school, probably none of you ever did this, but I did it. you know, I'd go in and I'd take an exam and walk out and say, phew, I don't have much now, you know. That's behind me, I can relax for a while, I can go out that night, party, you know, take the next week off, not study too much, whatever, and then the next exam comes along and you cram, and sometimes undergrad can be like that, okay? That's a disaster for medical school. Medical school is slow and steady, it's a marathon. If I go, the students are there every night studying, okay? You can't, it's hard to take off a night in medical school from studying. Everyone will tell you that the hard part about medical school is not really understanding the material. You make it through college and these courses and all that, physiology, whatever, you're going to get to medical school and there'll be very few days where you walk out at the end of the day and say, well, I have no idea what they were talking about. I don't know, I don't understand this at all. But every single day you will walk out saying, oh my gosh, how am I going to learn all this? How am I going to, you know, put this all up into here? How am I going to organize this? That's the hard part. You're pretty much, the whole time you're in medical school, Monday mornings you feel like you're kind of caught up. By Friday afternoon, it's like, oh my gosh, the weekend's here, thank God I can study all week. Another thing that's a little different with DO schools is that we have a, we don't have one hospital that we're affiliated with. We have several, and this list is sort of outdated. We actually have 13 spots. And you go to one of these spots for 6 months. You do a 6-month core there. Maybe you go to, it's not on here, maybe you go to Memphis for 6 months and you do your core there. Now after your core, you can stay in Memphis for the whole 2 years if you want. Okay? If you're married or you have a spouse and you have kids, it's harder to move around. So you might want to stay, get somewhere, your husband or wife gets a job, your kids get into a school, and you park it in Memphis for 2 years. But if you're single and mobile and you don't care where you go, you can go all over the place. Okay? You can go to California. If you were from Florida and you want to come back to Florida, you can come back here for a lot of your, pretty much half your 3rd year and the majority of the 4th year. Okay? It can't be the whole 4th year. There's a couple of things you have to come back to our neck of the woods for. But pretty much a year, almost a year and a half, you can come back here. Okay? Or if you're from California, you can go there. Let's say you're from Florida and you want to come back here. We have lots of spots in Florida, and we might be able to accommodate you, okay, with just our spots. But if we don't, you can also arrange spots to rotate that. You can kind of be the intermediary. Let's say you shadowed a doctor here, and you want to come back here and work with that doctor. Basically, there's some forms we all sign. They sign the forms, we sign the forms, and that doctor agrees that they're going to educate you for a month. Okay? And then from that, you can usually find other contacts and come back to it for a while. I had a student who had a mobile home, and she just traveled around and lived in it for 2 years, going somewhere different every month. The technology, it's very high tech. Everyone gets a tablet computer. All the lectures are videotaped, okay, so you can, just like here. You can go home that night and watch the videotape, or 2 years later you can watch it. Let's say it's you get the anatomy of the knee joint in your 1st year, and now as a 4th year student, you're doing a surgery rotation, and you're going to be working on the knee. You can watch that lecture again. All the tests are on these tablets, so that students live in them constantly. We have 33 study rooms now.
Are they, because you mentioned about the videos that you can come back, so basically like 3 years after and watch this, is it the same video or is it updated?
That's a good question. It's the same, or you can watch other lectures, okay? In fact, I always joke with the faculty that when we die, they don't really need to replace us. They can just put the video up, okay? Or let's say one of us dies and they bring in a new professor and he's not very good. Students can really say, well, let's watch the dead guy's video. Right? I mean, it's there forever. So you have lots of choices. And you'll actually, in these study rooms, there's 3 walls that are whiteboard, and then 1 wall is a monitor. And you can plug your tablet in here. And what the students will usually do, you'll see them the night after the lecture. With the lecture plugged in here and up on the wall, and you'll see 7 or 8 of them sitting around watching it. And if it's a confusing part, they can, you know, hit pause, talk about it, figure out what the person was saying, and then move on. Some of us, they'll play at double speed, and some of us, they'll slow down. So they have ultimate control over all that. We're big on group studying, which I think is a good habit as an undergrad to get it. Medical students pretty much study together all the time, okay? You go up to these rooms at midnight, they're there, middle of the night, early morning, they're in here studying. It's a good thing to read for a while, but then go in with your group with 7 or 8, 5, 6, 7, 8 people and take turns going to the whiteboard, diagramming things. That's a great way to learn it. Try to teach your classmates, okay? Because one of the things with medical school is you got everything you're doing from the first day on for that whole 2 years is stuff that you want to get it into long-term memory. You want to do well on the test, but you also want to get it into long-term memory, okay? You know, you might take an undergrad class where, okay, am I really going to use this again? I don't know. I mean, there's classes, I took chemistry like 30 years ago. I wouldn't remember much of it right now, okay? But all this stuff you're doing is things you're gonna need to know for the boards, for rotations, all that kind of stuff. And that's a much better way to solidify it. Just talking about it and not just practicing for the test. This is the original anatomy lab. We now have a new anatomy lab, and this is going to become a surgical training center. You can see some cadavers out there. It's all very high tech. There's a camera you can move around. Like if you find something interesting in one of the cadavers, the camera can focus in and you can show it on all the screens. That's the OPP lab. This is the clinical testing area, and there's 10 of these rooms. And this is where, even as a first-year student, first semester, you're going to be the doctor. They're going to say, okay, 8 o'clock Monday morning, put on your white coat, get your stethoscope, and you're going to see 10 patients that day. And you'll go to outside the first room, and there'll be a computer and a monitor, and you'll look at the electronic medical records, just like the real world, nothing's paper anymore. You'll go in, you'll examine the patient, do a history and physical, come back out, write up your diagnosis, your treatment, and then on to see the next patient, okay? The whole time you're kind of being timed. Yeah.
So are there like actors or whatever?
Yes, these are all actors, yeah. And so we have a group of about 50 actors, and they're all trained to go through this like they might be a Parkinson's patient for 150 students. So they learn what medications they're taking and their symptoms and all that kind of stuff. Some of the actors, they're actually, you might have a 60-year-old actor who has Parkinson's disease. So